Hey everyone, thank you so much for joining us this evening. I'm really excited for tonight's topic because migraines are something near and dear to my heart, for better or for worse. We are actually joined by our new host for the DPC Grand Round series, Dr. Tiffany Leonard, who's taking over for Dr. Thomas White. And tonight's guest is Dr. Kissy Blackwell. So with that, thank you all again. Actually, a quick note, at the end of this event, I will be posting the CMA survey in the chat and emailing it out to you, as well as a certificate form for your CME credit that Dr. Tiffany Leonard helped secure for everyone. So with that, Dr. Leonard, the floor is yours.
Hey, thank you everybody for joining us tonight. This, I'm sure, is going to be an excellent program that Kissy has put together for us. I don't think she needs any introduction because I'm sure you guys all know and love her as much as I do. But in case you've had more to drink than me, tonight is Dr. Kissy Blackwell, who's going to talk to us about the advances in migraines and migraine management. Take it away, Kissy.
All right. I'm so glad to be here today. Hopefully I can answer some questions and elucidate a little bit of this for you, especially some of these new treatments. So let's get started. Maybe. There we go. So just to start, I have no financial disclosures or conflicts of interest with the presented materials. So our learning objectives today, we're going to describe the available pharmaceutical treatment options for migraine headaches, including acute and prophylactic treatments. We're going to understand the different types of nerve blocks available for recalcitrant migraine treatment and how to perform them, and also describe new treatment options available and the mechanisms behind these new therapies. So just sort of a very basic definition of migraine. It's a complex neurovascular disorder that affects about 12% of the general population. More women are affected than men. It's characterized by intense head pain that can be accompanied by sensitivity to light, sound, and nausea. And surely there's a lot more to this as well, but this is sort of the basic definition. So there's 4 phases to migraine. The prodrome, which kind of involves just, and your patients may tell you this, like the day before they get a migraine or a few hours before they get a migraine, they may get just these feelings of, I don't feel right. I just feel weird. Something's not right. They may feel irritable, depressed. They may start yawning a lot. It says euphoria. I've never had a patient tell me that they were euphoric, but possibly that's the case too. The second phase is aura. So this involves either visual aura, sensory aura, language and motor, which can happen with hemiplegic migraine. And then you can also have aura without headache. Then the third phase is the headache phase, tends to be usually unilateral, throbbing, pulsatile in nature, usually, not always, involves nausea, vomiting, phonophobia, photophobia, osmophobia, which is just aversion to certain smells, and cutaneous allodynia, which is where they just feel like non-noxious stimuli can actually cause pain to their skin. And then the postdrome, which is where you're kind of finally sort of relieved from some of this headache, but the head movement can cause pain in that area where they were feeling pain before. Sometimes they feel drained or exhausted. Again, others feel euphoria or elation. I don't think I've ever had a patient tell me that, but apparently that's possible. So what causes migraine headache? Of course, we used to think that it was just maybe a vasodilation problem, but that's really not a viable explanation anymore, and it's much more complicated than that. So basically, it's a primary neuronal dysfunction. We don't really understand how it primarily starts, but we do know that once it starts, there's sort of a sequence of events that leads to both intracranial and extracranial symptoms. So it usually starts with this, what we call a cortical spreading depression, which is just a self-propagating wave of neuronal and glial depolarization. We don't know why that starts, but once that's started, that sort of starts the process. We think that the cortical spreading depression is actually what causes aura. And then this in turn activates trigeminal nerve afferents. And so basically this causes prolonged activation of trigeminal pain signals, and that's what generates the pain of the migraine. It also activates an inflammatory cascade around the cerebral vessels, which we call neurogenic inflammation. It's a sterile inflammation, so there's no infection or bacteria, but there is quite a bit of inflammation. And then it also alters the blood-brain barrier permeability, which causes leakage of plasma proteins, inflammation, edema, and that sort of thing. So this is really much more than just a vasodilation problem. So what's neurogenic inflammation? This may be a new term for a lot of people. So stimulation of the trigeminal ganglia actually causes release of vasoactive peptides. That's mainly substance P, calcitonin gene-related peptide, which we'll talk about a lot more later, and then neurokinin A. So this is a sterile inflammatory response that has, 3 components. I put 2 there. The first is vasodilation, which we knew about before, but this is not the complete picture, of course. Mostly that's activated by CGRP. There is a plasma protein extravasation, which is that permeability we talked about, and that's mostly activated by substance P. And then we have degranulation of mast cells releasing histamine, which also kind of propagates that inflammation, that inflammatory response, which is also mediated by CGRP. So the cause, so this is actually thought the neurogenic inflammation is the cause for the prolongation and that intensifying of the migraine and that pain that people feel. So it sort of starts with that depolarization, and then it just sort of continues to propagate with this inflammation cascade. And so this may also lead to something called sensitization. So let's talk about that a little bit. So sensitization is the process by which nerves become increasingly responsive to pain and both non-painful and painful stimuli, both centrally as well as peripherally. So that means that the nerves are activated at lower levels of stimulation, which is where people get allodynia. Magnitude of the response increases where they just have more pain. And then expanded receptive fields and also spontaneous neuronal activity. So the neurons just kind of fire at will without any stimulation. So this is thought to be clinically responsible for the throbbing, the pain that's worse with coughing and bending, the hyperalgesia, as well as the allodynia. So we'll talk a little bit more in detail about CGRP because there is some new treatments available that are CGRP receptor antagonist. And so basically CGRP is calcitonin gene-related peptide, which is a neuropeptide that's expressed in the trigeminal ganglion nerves. It's actually a potent vasodilator of cerebral and dural vessels. There's a little bit of thought that it actually helps with when people are having like stroke or other types of cardiovascular problems, that it may actually help dilate the vessels and sort of protect and have some protection against more stroke damage. So that's a really interesting thing, and we'll talk about that a little bit later. So it does mediate trigeminal vascular pain transmission from the vessels in the brain to the central nervous system. It also causes the vasodilatory component of neurogenic inflammation, dilating the vessels. And the induction of mast cell degranulation, which we talked about earlier as well. So let's move on a little bit to treatment. So there's a whole bunch of different things to go through, a lot of different things, and that we won't go through everything because we just don't have the time. But I definitely want to talk about kind of the main things we use to treat, and then some of the newer things, as well as some of the more interventional things, which is actually kind of my favorite thing. So let's talk about triptans a little bit because this is the most common thing that we use. So they're serotonin 1B, 1D agonists. They inhibit the release of vasoactive peptides, which basically decreases that extravasation of proteins that we talked about and decreases the neurogenic inflammation. It does promote vasoconstriction, which is actually the reason why these are not favored in people that have cardiovascular disease. And then it also blocks pain pathways to the brainstem, which is the actual 1B, 1D agonist pathway, essentially. It comes in they come in many different forms, oral, sub-Q, and intranasal. Of course, sumatriptan is the one that comes in all 3. They can actually be much more effective in combination with NSAIDs. The only one that's actually been tested is the sumatriptan naproxen combination, which I think is marketed as Trexamet. It's really expensive. So a lot of doctors will try to use the sumatriptan and naproxen separately, which is effective as well. They haven't studied any other combinations, but it's certainly possible that other combinations can be effective as well, since we're both, we're basically kind of targeting the inflammation at that point. So the reason that you only can get, 8 to 10 pills a month is because if you use it more than 10 times per month, it can cause a medication overuse headache. So the more you use it, the more headache you get. And so we definitely want to prevent that. And it's part of the reason why they don't give you more per month. So we do, of course, want to avoid these types of medicines in people with hemiplegic migraine, migraine with brainstem aura, ischemic stroke, ischemic heart disease, Prince-Meadows angina, uncontrolled hypertension in pregnancy. And that's just because they do promote vasoconstriction. So we do need to be careful. And then these are, of course, some of the different types that are out there right now. There's a whole bunch of them. So, of course, in the ER, you will actually see a lot of antiemetics being used. There have been good studies on both Reglan and Compazine. So you'll see that used in the ER sometimes, IV Reglan specifically, and then IM or IV Compazine are both used in the ER for monotherapy. So you can use them without any other medications, and they do seem to be effective. Apparently it is because they are dopamine receptor antagonists and seem to have some effect on decreasing nociception or pain, feelings of pain. It usually is given in combination with Benadryl to prevent the akathisia as well as the acute dystonia problems that can come with these medications. But there's also some evidence that Benadryl also can decrease the headache as well, because it's going to decrease some of your inflammation, which is actually a good way to do things too. So the other antiemetics that we use, the orals especially, we don't want to use those as monotherapy because they're really not as effective. During migraine, there's a lot of trouble with sort of gastric slowing, which is why people get nausea. So they may not be as effective orally. But we can use them as adjuvants, especially if people aren't having like super horrible nausea or vomiting. So a lot of people will use promethazine, Zofran, or chlorpromazine. So those are other options as well. So this one's kind of interesting. It's marketed as Rayval lasmiditan, and it's a selective serotonin 1F receptor agonist. So it blocks a little bit different path than the triptans, but it has pretty much the same effect as triptans, except that it doesn't have vasoconstrictor activity. So this can be a good option for patients with contraindications to triptans, but they still do well with triptans. You do 1 dose per 24 hours. It does seem to be modestly effective in trials. The only issue with this medication is that there's a lot of adverse effects. They can't drive, they can't work, they'll get dizzy, they may feel sleepy. So you do need to kind of caution them if you do give them this medication that there is some potential for some adverse effects, that they may not be able to use this while they're at work or if they need to drive somewhere. So the CGRP receptor antagonists are the newer drugs that have come out. In fact, it had been many years since there had been any new treatments for migraine. So it's kind of exciting to see that there are some new things out there. So there's 2 types. There's the monoclonal antibodies, which are the injectable form, and we use these for prevention, not for acute treatment. And then the small molecule, which they call GPANTs for acute treatment, are both directed at the CGRP receptor. So they antagonize the receptor and block the function of CGRP. So the receptors are actually found in the synapse of the trigeminal afferent nerves, which is the ones we know cause pain during migraine. They're found on glial cells as well as meningeal and cerebral arteries, which cause the vasodilation, and then on mast cells, which is why you see the degranulation of the mast cells as well. So these are the different types of monoclonal antibodies that are out there. Different types of CGRP receptor antagonists out there. The monoclonal antibody is usually used once monthly for migraine prevention. There is actually another one, which I didn't list here, that's actually an infusion that can be done IV once every 3 months. And so that's a really interesting one too. Usually you would see that in a neurologist office where they did infusions. And usually we use these for patients that have at least 15 headaches per month. And at least 8 of those headaches need to meet guidelines for for migraine. So they meet criteria for migraine, that's what I'm trying to say. And then the GPANTs, which are the small molecule ones, these are all oral treatments and they all are for acute migraine treatment. Although Nurtec has actually been shown to work for prevention as well, which is interesting. The Ubrelvy and Nurtec are the 2 GPANTs that are out there right now. There's actually one other one that just came out, I believe, last month that I did not list here, but it should be coming down the line, and it's actually for prevention. I do think I have that one in here later. So this is kind of a nice slide showing sort of the mechanism for the relief of migraines via the receptor antagonists. So you can see at the top here, you've got the CGRP that's released from the trigeminal nerve, and it can bind onto the mast cell receptors, which releases the histamine and causes inflammation. It also binds here to the smooth muscle cells in the meningeal vessels, the epithelial cells in the meningeal vessels, which actually cause increased permeability. And that's where we get that plasma protein extravasation. And then down the line a little bit, you also get release and onto the smooth muscle of the cerebral arteries, and that causes the vasodilation effects that we see in the cerebral arteries. And then lastly, there's also CGRP in the synapses in the trigeminal afferents, and this is where we get propagation of pain signals. And so if we're blocking this, we're also blocking the pain signals. So this, of course, is my personal favorite, is the peripheral nerve blocks. So we usually don't do this right off the bat. This is, of course, something that we do if patients are really having trouble controlling a migraine, or if they have an intractable one where they're just going for days at a time with migraine, then we will try these peripheral blocks to try to help them relieve the pain. So the first one is the occipital nerve block. So with this, we block the greater and the lesser occipital nerves. I usually use 1% lidocaine because it's what I have in the office, but you can also use Marcaine without epinephrine. You want to inject about 1 cc per nerve, and I usually also inject about half a cc in the suboccipital region just to get some of the nerve fibers that may be proximal to your injection sites. And I just learned that from watching many videos of people doing this. It seems to be more effective. And the possible adverse effects of this, of course, are vasovagal syncope. So you need to be prepared to lay them down if they feel like they're going to pass out. Transient dizziness following injection. And then, of course, you need to make sure that you're aspirating before you inject so that you don't end up injecting this intravascularly, which is pretty rare. I do have a little video that I wanted to show.
Okay,
I'm going to fast forward this just a little bit.
Use a 27 gauge 1-inch needle.
Dr. Blackwell?
The injections, yes. We want to make
you may need to share the screen your video is playing on.
Oh, I'm sorry. I'm sorry.
No worries.
I clearly don't know how to use this. Hang on a second.
There you go.
Okay.
To the periosteum. So angling the needle upwards and making sure that the needle is snug against the periosteum. Support the needle, pull back to make sure there's no blood flush. And I'm going to inject a full 1 cc of Marcaine. And this is 0.5% Marcaine without any epinephrine.
So this is the greater occipital nerve, and I'll show you the anatomy in a minute.
Fluid has expanded the soft tissue, and the patient will feel a pressure-like sensation from that injection. Now for our lesser occipital nerve, we're going to go laterally, and we're going to repeat this, again, angling the needle up and making sure that we hit the periosteum. That gets us close to the nerve, pulling back for the blood flush, and then injecting 1 cc of Migraine at this point. I like to finish the procedure with a third injection that I do just suboccipitally to capture any of the fibers that are traveling up from the splenius capitis as they extend up over the knuckle ridge to get to the skull. So in this suboccipital location, we won't be hitting periosteum, and we're going to inject just half a cc of Migraine at this point.
All right, so you can see here, let me open this up a little bit, and I need to share the other screen. All right, can you see the right screen? Yes, okay. So the occipital nerves, basically what you do to find them is you go to the base of the skull, where you have sort of the highest point there, and you can kind of feel that knuckle ridge. And then you will draw a line to the mastoid process. And if you draw a straight line in between them, you can see that 1/3 of the way is your greater occipital nerve, and then another third of the way is your lesser occipital nerve. So what I do is I just kind of find the middle, and then I just go to either side about 1 centimeter or so to find each of the nerves, and then kind of inject just underneath too to get some of these afferents coming this way. I'm having some trouble with the PowerPoint. There we go. So the next one is the sphenopalatine ganglion block. This one is actually one of the first ones that I ever did. I had a patient come in saying that she was getting these types of blocks from her neurologist, but then she was telling me that she wasn't actually getting it from the neurologist. It was being done by her nurse practitioner. So I thought, you know, I could probably do this. So I tried to kind of research and figure out what this was and how to do it and what to do with it. And so I finally came across all these things, and it's actually a very simple procedure. I did a little video on Facebook, of course, with permission from my patient to post this, about how to use the sphenocath, which is that first one that you see there with the 3 special types of catheters. So there's several ways you can do this. You can use one of the special catheters, which is sphenocath, Alivio, TX360. Those tend to be pretty expensive, especially because you do have to buy either a 5-pack or a 10-pack. So you can't just buy one catheter at a time, unfortunately. You know, I'll usually charge my patients $75 to $90, depending on, you know, how many they need done. You know, if they're just trying it out, sometimes I won't charge them as much. So anyways, they do usually last up to 6 weeks, which is nice because some of the other techniques like the angiocath and the Q-tips, because they're not targeting the ganglion directly, they don't last as long. So people may get a few days of relief, but they won't get that 6 weeks of relief. So that's what's nice about the special catheters. So I'll go ahead and play this video, which I think is inside my, well, maybe. Oh, I'm sorry, I'm getting the pinwheel of death. Hang on a minute.
Precisely what every presenter wants, right? The pinwheel of death.
Right, yes. Okay.
You're totally good.
Let me, when it stops, I'm going to just come out and come back in if I can get it. It's not doing anything for me now. Oh, come on. Of course, it was working fine last night.
In the meantime, we do have a couple Q&A questions if we want to address those outside of Q&A order. Dr.
Sure.
Leonard?
Watch my video start in the middle of the question here.
I'm not sure I see Q&A questions. Honestly, I see chat, but I didn't see a whole lot of questions in there.
All right, well, I may have to just move on from this because this I don't think is going to work for me.
That's totally fair. I can field the Q&A question. So the first is from Dr. Gar Sorgen. Can you explain what brainstem aura is?
Brainstem aura, yes. Of course, so aura, of course, we think is caused by that depolarizing wave. So that depolarization wave actually can happen in the brainstem. And so they can have all kinds of weird symptoms, like they can actually have decreased CNS response. And you know, I knew somebody was going to ask me that because, and I don't remember the rest of the list of things that can happen, but basically what you're worried about is that they may end up having so much CNS depression that they stop breathing, and you don't want that. So that's the reason why you need to be careful with using triptans with those types of migraine.
So we're doing Phenocat today. We've already done.
Oh,
Sounds like a video coming in.
Yeah, I'm trying to get it loaded up on mine, and I'll just screen share the video from mine.
Perfect.
Just give me a second here. Let me mute me over here so you don't.
Okay. Well, while we're doing that, I do want to talk about the other type. So you can actually do just a flexible angiocath attached to a syringe in order to do this. The angiocaths, of course, a little bit shorter than what we use with the special catheters. And I actually have seen some videos with ER doctors doing this for acute migraine, which works really well. You can also use a hollow cotton tip applicator, and I do have a picture of that here just in a minute. And Tiffany, whenever you're ready with the video, if you can.
Okay, all I can find is the actual thing on Facebook, but that's okay.
Sorry about that.
So I'm going to stop yours. And let's see, this should work. Don't mind my 5,000 open windows, folks. Can everybody see a picture of Kissy?
Yep. You were not kidding about those tabs.
So we're doing Phenocat today. We've already done one side, and I remember that you guys wanted to do this and show it to you. So I've got usually up to 3 cc's on this, and it's 1.5 cc's per side. So we've already done one side, so we've got 1.5 in here connected to the Phenocat. You can see how it goes in and out. And we've got it in right now because we're going to go in and then insert the count. So I'm just putting a little bit of light. We've already prepped her with a little bit of Afrin and a little bit of the lidocaine jelly in her nose already. So she's hopefully as comfortable as we can possibly make her, although this isn't super comfortable. So then we kind of go sort of level to her face here. And then you want to sort of point this arrow towards her septum. And then you're going to go all the way. So you hit kind of a stop. Looks like it's about 4.5 centimeters. Pull back just slightly and then go in with the catheter. Inject. Pull the catheter back up. If you want to get closer, you can see her eyes turning red and she's watering. So that means we've gotten it in the right place. So now we kind of leave her in this position for about 10-15 minutes until things sort of start to settle out. Sometimes they do get a little bit of stuff going on the back of their throat, but they shouldn't feel a whole lot of that. And then usually we'd also have a temperature gauge here, but since we use this catheter, we don't have the temperature gauges. You would see the temperature go up about a degree or two. So anyways, that's it. Super simple, and I think pretty much all of us can do it. They're about $90 a calf, and that's a lot less expensive than going to a neurologist. So thanks.
Okay, back to you, Kissy.
All right, thank you. I appreciate you doing that.
Pinch it here.
Back to my PowerPoint here. All right. So, oops, back. So this is kind of interesting. I have not used this technique before. I do use the hollow cotton tip applicator, but I usually just stick it straight down. So I've never seen one angled like this, but I thought this was kind of interesting because you might actually get to the ganglion a little bit better. So this is a little bit different because when we were looking at the sphenopalatine block with the catheter, the special catheter, we're actually going straight this way with the catheter. Can you see my arrow? Oh. Can you guys see my arrow when I'm moving it here? Yes, okay. So we're going straight back this way with the other catheter, whereas with this, you're actually going straight down. So you're actually going to be going sort of 90 degrees to the nose. And so then you can actually take your syringe and needle and drop the lidocaine down the hollow tip tube. And usually I don't do quite as much. I don't do a whole cc.5 here because a lot of it goes down their throat. So I usually do maybe half a cc and just whatever they can tolerate at that point. Usually about half cc is about all they can tolerate, and they get pretty good relief from that. And so this is interesting, like I said, because I haven't seen it done this way, but I'm not entirely sure how you would get the swab in there while it's in that angle, but I guess there's a possibility you could. It seems pretty uncomfortable, but anyways, it is a good way to do it. You don't have to bend the swab like this, but it certainly does help to get some of that numbness going in that ganglion. All right, the next one is the supraorbital nerve block. So this, of course, is blocking the supraorbital nerve, which is just above the eyebrow at the supraorbital notch. This actually works really well if you have like a laceration of the forehead as well, to block the forehead area so that you can do your sutures without too much problem. There's some evidence that a combination of the greater occipital nerve and the supraorbital nerve block can be effective in long-term treatment of refractory migraine. So this is kind of interesting. They had a study where they injected people, I believe it was 10 times out of the month. And they actually found long-term relief from people getting multiple injections like this. So not sure why that works or why it happened. It was a very small study, so I'm not sure how reproducible that is. But it's interesting to note that there's a possibility you could actually have some long-term relief. These are just some other kind of drawings about the different types of blocks. So here's your greater occipital nerve and your lesser occipital nerve. And then of course, here's your supraorbital nerve. Some of these other blocks are not exactly for migraine, although they can be used too. Again, so you've got your protuberance here, your inion, and then your mastoid process. So you draw a line between those. And then about a third of the way is your greater occipital nerve. Another third of the way is your lesser occipital nerve, which is how you find your landmarks. And then here with the supraorbital nerve, you're going to kind of find the notch, and that's where you want to go into your to do the supraorbital. I do have a video of this if it'll work. Apparently not. My computer doesn't like me today.
Yeah, I don't know if I'm good enough to quickly find that one.
Oh,
I was going to say, we can field a question while we wait.
I'm sorry, let me see if I can get out of this and keep moving forward. So supraorbital is pretty simple. You're just really injecting right at that supraorbital notch where the nerve is coming out. You inject about a cc there and you do pretty good. Let me see. I wonder if it'll, no, never mind. Okay.
Dr. Blackwell, really quickly, if you want, so we've already had a request if you'd be willing to share your slides after this, we can send it out.
Yes, absolutely.
With the post-event materials, but if you send us the URL, we can also make sure that everyone has access to those videos.
Yes, absolutely. Actually,
Perfect.
am I not sharing my screen anymore? There we go. Okay, so the next thing I want to talk about was cryotherapy, because ice can actually be really effective. Of course, we know that ice is effective in general for inflammation. And so now that we know that migraine is actually an inflammatory response, we can see that ice can be helpful for this too. It's very interesting. One of our own, Dr. Farago, actually has created a device for this, the cryo helmet. I don't know if you guys know anything about it, but I actually have one right here. So there's a bunch of ice in it and you just put it on. And there's also ice in the neck part of it as well. So it just basically hugs your whole head with ice. A lot of patients find it really, really helpful, even if it's not like, even if it doesn't completely take away their headache, it just feels good. So I think it's a really nice way to do things. I do have a little video of Doug, but I will let you guys watch that on your own. So the nice thing about ice is that there's no side effects. It's easy to use. You can pretty much get it anywhere. So it does, questionably, it decreases inflammation and maybe triggers some vasoconstriction, which actually may help the headache go away. There are some small studies that show some modest benefit, but really anecdotally, I've had lots of patients that feel like it's helpful. All right, so the last thing I want to talk about is prophylaxis for migraine. So the indications for prophylaxis are people that have frequent or long-lasting migraines, headaches, attacks that cause significant disability where they can't go to work and that kind of thing, or diminished quality of life. They can't spend time with their families, that kind of thing, despite the appropriate acute treatments. They may have contraindications or serious adverse events to the acute therapy. So that would be another indication for using prophylaxis. They may have had failure of acute therapies. And before it was just really, we didn't have a lot to offer other than the triptans and some of the nausea medicines. And so now that we have some new things, hopefully there will be an acute therapy that'll work for your patient. And then of course, with these medicines, there is some risk of medication overuse. So if they're using it, 10, 15 times a month, which they really shouldn't be if they're not getting that many, but sometimes they do, then they can actually just end up propagating the headache. And so to kind of break that, you want to maybe try to use some prophylaxis instead. And then apparently there's also some evidence that with menstrual migraine, it's good to use prophylaxis as well. So the goals of therapy for prophylaxis are to reduce attack frequency, severity, and duration, to improve the responsiveness of acute treatments, which is good because they're still going to have some breakthrough headaches. And so you still want something for them to have for acute therapy. And so it may actually improve the responsiveness of these acute therapies, which is great. You also want to, of course, improve their function and reduce disability so they can go back to work, they can go back to being with their family. We also think that it may prevent the progression to chronic migraine. And may actually reduce the risk of neurologic damage, especially from like hemiplegic migraine, the migraine with brainstem ARA, which I should have looked up a little bit more, I guess. And then the persistent ARA without infarction, migrainous infarction, all of those things, we want to reduce the risk by using prophylaxis. So some of the pharmacologic therapy that we use for prophylaxis includes antihypertensive. So we all know propranolol. A lot of our neurologists also like to use verapamil. There is some evidence that ACEs and ARBs can actually be helpful as well. So that's interesting. I had not noticed that before. Antidepressants can also be helpful, like amitriptyline and venlafaxine, which are the two that have been studied the most. I have seen people on Cymbalta as well for it. That seems to be really helpful. Anticonvulsants like valproate and topiramate can also be helpful for prophylaxis. And then, of course, your newer drugs, which are the CGRP antagonists. Most of these are injectable. This is the IV one, which is called Vyepti. And then this is a new oral preventative, which is called atogepant. This one is not, I think this one just came out maybe last month. So it's not, I don't know if it's on the market just yet. I don't even know if it has a name yet other than just the generic, but it should be out pretty soon. And this one's for prevention. So it's the only one that's an oral prevention out of this group of medications. Now, off-label, people have used Nurtec, which is one of the other gepants that's used for acute therapy. But they have used it. If you use it like every other day, you can actually get some decrease in some preventative therapy too. So that may actually be coming out with a new indication at some point. So the CGRP receptor antagonists for prophylaxis, they decrease pain propagation and vasodilation and that permeability that occurs during the neurogenic inflammation. And this is kind of what I talked about earlier, whereas there's some theoretical cardiovascular risk with these. Because CGRP was kind of theorized to act as sort of a safeguard, like for vasodilation during like cerebral as well as cardiac ischemia, they did not see any of this in the trials. So none of this has actually been proven, but it's sort of a theoretical risk. And so something that still probably needs to be looked at and studied just to make sure that these are safe for cardiovascular risk patients. But they do seem to be a little bit less problematic for people that can't do triptans. These tend to be a little bit safer. All right, so other potential treatments for prevention, of course, you have your Botox, your botulinum toxin. Usually you would have to have chronic migraine to use botulinum toxin, which means that you have more than 15 headaches per month for at least 3 months, and 8 of those meeting the criteria for migraine. Coenzyme Q10 has also been shown a little bit to have some prevention for treatment. They think that it may be because it improves mitochondrial function. So they think there is that potentially that cortical depression that we see that we don't really know why it happens. They think it could be because of mitochondrial dysfunction. And so coenzyme Q10 does seem to have some effect. Magnesium has kind of had some mixed results in trials, but I certainly have some anecdotal evidence that magnesium is helpful for some patients, so it's worth a try. And then riboflavin, or B2 at 400 milligrams a day, did significantly reduce headaches, but the effect only occurred after 3 months of treatment. So this is one that, you know, hey, patient, take this every single day for 3 months, and you may see some results. So it won't work very quickly. And then, of course, you have some non-pharmacological interventions, including the injections that we talked about, but there's also acupuncture. Acupuncture hasn't been shown to be more effective than what they call sham needling, which is where they're just putting in needles but not really actually doing the therapy. And then not more effective than traditional medical therapy, but certainly in patients that can't take drugs for whatever reason or don't want to, it can be beneficial. There's also transcutaneous supraorbital nerve stimulation. So if people get good relief with supraorbital block, then nerve stimulation might actually be a good option for them. And then there's been some studies too. There's actually some devices that were approved by the FDA for transcranial magnetic stimulation. Usually for prevention, it's used at 4 pulses twice a week. And if they have a migraine attack, they can actually use it repeatedly up to 3 times. And so this has been shown to be helpful as well. All right, well, that is all I have. So maybe there's some more questions that I can answer, hopefully ones that I can answer.
Well, so we do have a couple in the Q&A, but if you don't mind, I'll go to swing for you here on the one that you struggled with. That calling the brainstem aura is what we used to call the basilar migraines.
Correct.
People that get some impaired hearing, double vision, ringing in the ears, vertigo, ataxia, altered level of consciousness. I've only ever seen 2 people in my entire career with it, and it scares the bejesus out of me when I do see it.
I've never seen one of those, but it definitely sounds scary.
Yeah, it's freaky. Me, myself, I have a tendency to lose vision in my left visual fields, so no triptans for me. But so your actual questions, how long do the nerve blocks last, and are they just for acute treatment?
Mm-hmm. So the nerve, so the occipital and the supraorbital, you can use them for prevention. One of my patients actually gets them every 6 weeks, so prophylactically, essentially. You can also use them for acute treatment. So if you know that someone is having a posterior headache all the time, or it's being triggered by spasm in the neck, you can actually do an occipital nerve block, and they should get relief of their headache pretty quickly. I actually had one like that the other day. She wasn't having a posterior headache, but she was having a frontal headache, and we did a SPG block with just the Q-tip and dropping it into the end of the Q-tip. And she got relief right away. She came in where she couldn't even like open her eyes, and she had like a you know, like a bandage around her eyes because the light was just bothering her so badly. And she was able to take it off and leave without it. So it definitely works for acute. But like I said, you can do, especially the combination of the greater occipital with the supraorbital can be used for prevention. And they usually last about a day or two. And I didn't find a lot of information about how long people get relief because, you know, sometimes they can have, it'll go away for a little while, but it'll come back. I haven't seen anyone that came back and said, oh God, Dr. Blackwell, that only lasted a few hours and it came back. But that's just a few patients that I've treated. So it's certainly possible.
So while we're talking about nerve blocks, can patients be taught to do the SBG block on themselves?
Yes, they can. If you use the special catheters, they can be reused. Obviously, you reuse them only in the same patient and not on other patients. But you can actually clean them with alcohol because, you know, you're not really doing anything super invasive when you're going in their nose. But they can be taught to do it on their own. If they can, you know, reach back there and get it done, then it's hard. I mean, if you've ever tried to stick something in your nose, it is not an easy thing to do. But they can learn, you know, if they're having a bad enough headache, they can absolutely learn. The Q-tip may be the easier one, but I have seen some people that I believe it was, I believe it was Debbie Sutcliffe that may have said she taught one of her patients how to use the catheter, the sphenocath, and that she was doing it at home whenever she had an acute attack. So yes, you can definitely do that.
Okay. And while we're staying on this track, would an SPG block help someone who's going through caffeine withdrawals? Tammy said she finds that patients aren't willing to give up their caffeine because of the debilitating headaches they experience.
You know, I'm not sure what the mechanism is of those types of headaches. So I'm not sure if we have the same pathophysiology, but if they do have some kind of nerve activation that causes the headache, then it could be useful. I don't know for sure because I don't know what the pathophysiology of the headache is from that withdrawal, the caffeine withdrawal.
And then they wanted clarification. When you use the Q-tip method, do you go superior into the upper nostril or parallel to the upper palate?
Parallel to the palate. So when you do the Q-tip, you're going straight in this way. I don't know if you can see, straight in this way. When you're doing the other block, you're going this way over the middle meatus. You're wanting to try to get over that middle, the middle turbinate in order to get to the ganglion. So it's a little bit different. And it's the reason why when the catheter comes out, it sort of curves down because you're sort of like going over and above and getting into that sphenopalatine area. And that's actually the reason why they bend that Q-tip, because if you can get it in and sort of get it up to the sphenopalatine ganglia, then you may be able to get a little bit better result. I have not tried that, but I may, now that I've seen it.
Can you discuss aura without migraine?
Yeah, so aura, of course, we think is caused by the cortical spreading depression, which is where you get sort of that initial wave of depolarization. So some people may get that initial wave of depolarization, but it not meet the threshold to like activate the whole rest of the response. And so they may not get headache. They may just have the aura and nothing else. So they're not getting the neurogenic inflammation if they're not getting the pain. There's also backwards where you get headache with no aura, but they actually think that the reason for that is that it's activating part of the brain that we're not aware of.
Okay. How do you go about getting samples of Ubrelvy and Nurtec?
I do have reps that come to see me. I actually trying to think how those reps came. I really think they just stopped by my office one day. For some reason, I get tons of reps that come this way, but you can actually go to their websites and request a rep. So that's one way to do it. I think with Ubrelvy, you can order online. So if you can, and I don't know which company it is with Ubrelvy. I think it's AbbVie. Yeah, AbbVie.
Yeah. Yeah, I think the new one that you were talking about is actually the long-acting version of Ubrelvy, because it's an AbbVie product as well.
Yes, I think you're right about that. I knew it was that same company.
And Cloda's advice was to prescribe it once and they all show up 3 days later.
What's that? Prescribe what was?
Prescribe one of the G-Pants once and the rep will show up 3 days later.
Oh, right. That may be what it is. Maybe I started prescribing it and the reps just showed up or so. Actually, I think what might have happened was that I ordered it online and then they show up because they're like, oh, hey, we saw that you ordered it. And, you know, I'm also in a really small town, so there's not a lot of specialists here. So that's probably part of the reason why a lot of the reps come see me, because they're not super busy with the specialists.
Okay. How much magnesium are good amounts to use?
Usually you're going to use probably 400 to 800 milligrams a day. You do have to be careful because the more you use, the more diarrhea you can potentially have. So most of my patients will take some of my younger patients will take 400. The older ones will take a little bit more. You know, depends on the patient and how much they tolerate. And kind of what effect they have from it. But the two patients I can think of that are taking out, the younger one, she's 19 and she takes just 400 milligrams and the other one takes 800. She's a little bit older. So age probably doesn't matter, but it really probably matters just what, you know, whether the patient will tolerate it and how much they may need to prevent.
Okay. And then for Botox, do you need special credentialing to administer it?
I don't know if you need to. I think you do. I think in order to order it, you have to be credentialed in some way, but I am not entirely sure exactly how that works. I know I don't think I've ever seen a family doctor doing it. I've seen some of the sports medicine doctors do it, so I don't know if, you know, I really don't know exactly if they have any kind of special credentialing or training, but I feel like they do.
Can you talk about differentiating migraines from intracranial, I believe, hypotension, ICH? Is an LP the only way to differentiate?
And I think it's intracranial hypertension.
Okay. In our chat, Kirsten Lynn said that she was diagnosed with hypotension, so I just took a stab in the dark.
You know, I'm not, and I didn't really look at this. I'm not really sure the type of headache that happens with intracranial hypertension. I don't think it's the same pathophysiology because I don't think you get the neurogenic inflammation, although you might, because you can see neurogenic inflammation with things like stroke and TIAs and things like that. And so, you know, could the hypertension activate the same cascade? It's possible. So you may get similar types of headaches with it. I think the only way to diagnose intracranial hypertension is to do an LP. I don't think there's any way to know for sure unless you do it. So that's all I'm not real sure about the rest of that.
Do you happen to know where Botox is injected?
No, I don't. I didn't look into that too much because I was really wanting to focus on the CGRP receptor antagonists since those were the new thing. So I didn't do much research about Botox.
And then somebody actually asked me specifically. So in chat, we were talking about, I told them I was going to tell them about a caution story I had. You always want to work up your patients with weird migraines and never just assume migraine. I have a very nice young gentleman who's actually my Ubrelvy rep, ironically enough, who started seeing me because he was having very weird headaches that he was told was hemiplegic migraines without any workup. Like his primary didn't even bother to do an MRI on him. And when I sat down with him and got his full history, he was having real concerning TIA-like symptoms, like episodes where he was confused and had no idea where he was or how he got there. And these have been going on since high school, so for over 10 years now. And he was getting sharp pains right here. Ooh, my hand disappeared, right here in the middle of his head. And to me, that screams vascular and not migraine. So I actually sent him urgently to a neurologist who did the same history I did, ordered a CT angio on him, an MRI with contrast to rule out tumor. did an entire endo workup. We're talking like 8 vials of endocrinology labs to make sure that it wasn't a cortisol problem or a FIO or anything like that. And literally everything came back normal. So we put him on verapamil, and 2 weeks later, his headaches are gone and he's had no more symptoms.
Well, good. I'm glad it wasn't more than what it was.
He's
I thought
lucky.
you were going to say he had like an aneurysm or something.
He's lucky he didn't have a stroke, honestly. They were putting him on triptans for his migraines. And I'm like,
Oh, you're kidding. Triptans.
yeah, he lucked out. So I think that's all I'm seeing for questions, other than somebody else said they find it interesting that MAG B2 and CoQ10 are also recommended for ADD.
It is interesting, and I'm sure that a lot of this is interrelated. And the other thing that we didn't really talk about is diet. I mean, a lot of the times diet changes can increase levels of CoQ10 as well as vitamin D and some of the other things that people use for migraine prevention. And so a lot of people that either do a ketogenic diet or a keto carnivore diet actually find that their migraines go away. So that's very interesting.
And then Wendy asked me how we made the diagnosis. Wendy, it's a diagnosis of exclusion. I've now had 2 patients in my career with it. The first one was not so lucky. She had what was called a thunderclap headache, where it's a very sharp, sudden, severe headache that's incredibly debilitating, worse than any migraine pain you can imagine. And those of us with migraines can imagine some pretty severe headaches. She presented to me with that. I thought it was thunderclap, scared the bejesus out of me. I tried to get her into neurology and I wasn't as effective with her. 2 days later, she had a stroke. So while she was in the hospital, they diagnosed her with a stroke, put her on blood thinners and the whole 9 yards. And then I called up a friend of mine down at UPenn Neurology, told them the story. And they're like, get her off the blood thinners and get her into my office tomorrow. So I actually had to maneuver a discharge from the hospital to get her to go see the neurologist at Penn. Which was awesome. And this guy, again, it was a diagnosis of exclusion. And I think the only reason it was on the neurologist's radar was because it was on mine because of the lady I had 6 years ago with the same problem. I really didn't want him to have a stroke. So, yeah, diagnosis of
definitely when you have those types of symptoms where you're having, weakness, numbness on one side, or, droopy face, or, all these things that we always worry about for stroke, like you don't want to just ignore that and say, oh, it's just your migraine. Make sure that they're not having stroke. And then if it's, something that you can rule out and say, hey, okay, this looks to be hemiplegic migraine, and, then make sure that you're not giving them triptans at that point.
Yeah, I've very definitely had the entire workup 3 times in my life because, like I said, several times now I've lost full left visual field. And it's kind of freaky when everything from your nose left goes black on you. We have a question that popped up. Do the CGRP antagonists work for patients with migraine headaches and abdominal migraines?
I didn't see anything about abdominal migraines. I think that's sort of a different topic, but I would imagine yes. There are CGRP receptors in the abdomen as well, in the gut, as well as in the heart, which is why they worry that CGRP antagonists can cause a problem with the cardioprotective effects during a heart attack. Again, it's the theoretical risk, so we don't know that there's really a risk at all, but yes, I do think there are CGRP receptors in the gut, so I would imagine that these could be helpful for abdominal migraine too. I don't know for sure, but I think so.
I would think so, because when the Ubrelvy gets rid of my migraine, it gets rid of all my abdominal complaints too. Mm-hmm. Associated with the migraines, not my gastroparesis. That nothing touches that.
That's a different story.
Yeah, that's a different grand rounds for a different year. And anybody else have any other questions? And if you can't see the chat, Kissy, you're getting several thank yous.
All right.
Okay, well, barring any other questions.
Yeah, seeing no additional questions, I think that we can wrap it up right on the hour. That is actually impeccable timing. So thank you all for attending.
Fantastic presentation, Kissy.
Yeah, seriously.
Yeah,
thank you to you both, Dr.
I'm
Blackwell.
sorry that I had some technical difficulties, but I think it worked out okay.
No,
it happens.
yeah.
We'll get the links out to everybody so they can watch the videos on their own time.
Exactly. So on that note, actually, perfect segue. So for those who attended, you will be receiving an email with both the survey for you to complete, as well as the CME certificate and the presentation slides with the links to the videos that were less than ideal in terms of working for Dr. Blackwell this evening.
Please do the surveys. I need that information to keep the AAFP monkeys off my back.
Yeah, this is true. And actually, you know what? I'm going to take this moment to, again, thank Dr. Leonard for securing CME credit for the Grand Round series to make life easier for everyone. So on that, please complete the surveys. It will take just a few moments. You will receive it in your email. It should probably be coming from the DPC Alliance's Zoom account. And thank you all for attending.
It's literally like 6 questions. I promise it's not bad. And thank you everybody for coming, and we will see you in our regular chat channels.
Yeah, absolutely.
Our next big event, I believe, is our lovely Talk with Me in 3 weeks on Facebook Live, I believe.
Yep.
So, you know, if you haven't gotten sick of listening to me yet, come, you know, ask me all your DPC questions in a few weeks.
Yep. So we have, like Dr. Leonard said, on the last Thursday of this month, which I believe is the 27th, we have the talk with the DPC doc, which is open for all DPC interested physicians, not just DPC Alliance members. And then actually immediately thereafter, we have a grand round. I believe it is Dr. Delicia Haynes on June 3rd with White Coat Safe Spaces, talking about depression and suicide in physician communities. So a very important and timely talk. We hope to see you all there. Thank you, everyone.
Good night.
Good night. Thank you.